Good afternoon, everyone. My name is Ella. It's my pleasure to welcome you all today. This webinar is taking place on March 5th, 2026. We are recording the webinar today so that we can share it with people who are not able to attend. This webinar is organized by the Manitoba HIV-STBBI Collective Impact Network. This is a network of innovators working collaboratively to transform the landscape of HIV and STBBIs in Manitoba. We bring people together to tackle complex HIV and STBBI systems barriers, and we seek systems change by shifting the conditions that are holding the problems in place. I'm speaking to you today from Treaty 1, Winnipeg, Manitoba. We acknowledge that we work and gather on the original lands of the Anishinaabe, Ojibwe, Cree, Oji-Cree, Dakota, Lakota, Inuit, and Dene peoples, and on the homeland of the Métis Nation. We are humbly working together towards the Truth and Reconciliation Commission's calls for action and the Missing and Murdered Indigenous Women and Girls Inquiry's calls for justice through our research events and projects of the Manitoba HIV-STBBI Collective Impact Network. If you would like to find out more about the Collective Impact Network, sign up to receive our newsletter, or find our social media and YouTube page, you can do so at cinetwork.ca. This webinar is part of our ongoing efforts to provide HIV prevention education, and you can find past resources on our YouTube page. We will have a question and answer period after the presentation today, so I ask that you type your questions into the Q&A feature. You can type a question at any time, and at the end of the presentation, there will be time for our panel to address those questions. So I will turn it over to our panel now to introduce themselves and the study. Thanks.
Thanks, Ella, and thanks everyone for being here today. My name is Tara Christensen. I'm a PhD student at the Faculty of Social Work at the University of Manitoba and a graduate research assistant on this project. I'm also a registered social worker that's practicing in the mainstream healthcare system in the downtown Point Douglas community area in Winnipeg. Red River Métis on my mom's paternal side, and also have settler ancestry from England, Scotland, and Ireland. A citizen of the MMF and a member of the Bison Local, and I'm happy to be here today. I just also want to acknowledge that our entire team consists of many different community organizations and partners, as well as a full community guiding circle. So many more people than what you're seeing on the screen here that have been involved in this work. So just want to acknowledge that and express gratitude to the folks that aren't here, but I'm joined by my other colleagues here, so I'll let them introduce themselves as well. Melissa?
Hi, Townsy. I'm Melissa Morris. I am a citizen of the Manitoba Métis Federation. I serve as the manager of the Village Lab in the Faculty of Social Work at the University of Manitoba, where I'm also an undergraduate student. In addition, I work with Gani Kanichak on the Indigenous HIV doula project. Albert?
Pat? Oh. Albert?
Yeah, I'm Albert McLeod. I've been working in HIV in Manitoba for the last 35 years. I work with a number of research facilities in Canada, the Fee Centre for Indigenous STBBI Research, CAN, Communities and Alliances and Networks for Indigenous Responses to HIV and STBBIs, as well as the Winiska Centre in Saskatchewan. Yeah.
Pat or Rusty?
Patricia Okoli. I'm a PhD student at the Faculty of Social Work, University of Manitoba. I'm also a graduate research assistant on this project. I'm a social worker and I work in community settlement agency. I'm originally from Nigeria. Thank you.
Hi folks, and I'm Rusty Suleimanov. I'm an associate professor in social work at the University of Manitoba. I've been involved in community-based HIV research for over 15 years, and I'm the principal investigator on this project.
Albert, can you please share a little bit about the name?
Yeah, as an advisor to the Village Lab around this particular research area, and I have worked for many years with the late Roger Roulette, who is an Ojibwe language specialist from Manitoba. And one of the philosophies he shares is Debwetamowin, which means the truth. And I think when you're examining history, colonialism, racism, that in our endeavors to research that area, that certainly we want to bring the truth forward. And so that is sort of the overarching philosophy. But also it's about dismantling colonialism and racism in the systems that harm. And that's institutional systems, organizations, etc., who are not well versed in anti-racism training and don't realize the harms that they do in the community.
Thanks. So just a little snapshot of HIV-STBBI Manitoba, where we currently have a rate of 4 times the national average, which is extremely high. And HIV is currently affecting Indigenous people at disproportionate numbers. And other STBBIs are on the rise, such as syphilis, gonorrhea, chlamydia, and hepatitis C. Rusty?
Yeah, so just a little bit about kind of the project focus. Our study really asks a fundamental question. How do racist policies within different institutions like child welfare, healthcare, public health, housing, justice, social assistance, immigration systems, how do all of those systems shape vulnerability to HIV and STBIs? Specifically for Indigenous as well as Black, African, and Caribbean communities in Manitoba. And rather than kind of focusing on narrowly on individual practices or individual behaviors, the project really examines how institutional logics, including colonial governance, racial surveillance, differential policy application, how all of that operates across interconnected systems. So that was kind of at the heart of the study.
At the heart of the study, we're really here to develop interventions that transform policies and procedures to better serve Indigenous, Black, African, and Caribbean communities regarding HIV and STBBI outcomes in Manitoba. And through our methodology, we come to this research through a community-based participatory approach, which builds off of existing relationships in the community, our community guiding circle, which I'm going to talk a little bit more on the next slide. And this project is elder-led by our trusted elder, Albert, and it's ceremony-based, which means that we start in ceremony, we continue with ceremony throughout the project, and of course, we end in ceremony. Our interviews are semi-structured interviews, which means that we can really break down, racism and colonialism. Sometimes those are huge concepts to people. And so we're really able to break down those questions so that people can best answer them. And we're currently doing our preliminary data analysis, presenting those findings today. And those are going to be presented through a thematic analysis. As I mentioned, we are led by a community guiding circle. We have 9 members that are both from the Indigenous community and the ACB community. We have people living with HIV, we have service providers, and we have community members. They lead us through all aspects of our research, including, piloting the interview guides, making sure we're on the right track with our findings, and participating in ceremony with us.
And so today we're honored to be able to share some of these initial findings with you, along with some of the stories that were shared with us by community. Many of the individuals I personally visited with or interviewed have acknowledged the importance for them to be able to share these experiences, because a lot of folks, express that they simply don't believe that they have been believed when sharing them previously. So we're grateful and honored to be able to provide that platform for those folks to feel heard and to present these findings and stories with you. And as Melissa mentioned, for us to then work with community through this shared knowledge to advocate and target specific areas to push for actual change. So to date, we've spoken with 31 individuals. So that's 31 interviews completed. 17 of those were with Indigenous relatives, 10 from the ACB community. And you see that breakdown here of specifics between service providers and community members. So we are going to talk about some of those common themes. Patricia's going to first speak about some of those common themes that were identified within the ACB community, and then I'll talk about the ones identified through conversation with Indigenous relatives.
Thank you, Farah. So today I'll be sharing our preliminary findings from our interview with ACB community members and service providers. We've done 10 interviews and 4 teams have emerged. And the first one is differential policy applications and racialized services for ACB population. So for the teams we see and interconnected teams of inequality, systemic inequalities, pointing how policies are applied differently for Black populations within Manitoba, leading to unequal access. We also see that being Black kind of increased the likelihood of encounter with child and family services with the justice system compared to our white counterparts. Like you can see from some of the stories that participants have shared. So I'll just give a minute for us to look at it and kind of picture what this means for ACB population living in Manitoba. The second team looked at child welfare surveillance and parenting scrutiny. And for this, we observed a focus on surveillance, heightened scrutiny encountered with CFS, with the justice system. And we found that parenting in Manitoba for ACB population was always called into questioning. So Black families face significant challenge with this institute due to systemic racism, anti-Black racism, and lack of cultural sensitivity. So parenting, Black families usually have to prove that they can care for their children or else risk having them taken away. Participants also shared that negative stereotypes, the labeling of Black parents as unfit and incapable, kind of which results from them having to prove that they can take care of their children. So like we see for some of the participants that have shared, most participants share that being Black means constantly being questioned. And another participant shared that raising children in Canada is kind of traumatic for Black populations because you have to let go of your training, you have to let go of your history, your culture, and still we are stuck with that label of unfit parents. Next slide, please. And another thing that arose was the structural racism in housing, in all the institutions, especially housing, justice system, child welfare, social assistance. And we see this problem all over, anti-Black racism in healthcare, which manifests as clinical dismissal, discriminatory labeling, and culturally unsafe models, right? And treatment disruption and lack of access. So we can see that from some of the stories that were shared with us by participants, which kind of highlight issues within the health system and also in other criminal justice system and others. Next slide, please. So participants discussed the stereotype, the judgment which they encounter in interacting with this system, especially in Manitoba. One participant shared that being Black was synonymous to crime for most of this agency. Another participant referring to the housing sector says they were refused housing because of being Black. So these are some of the things that participants highlighted in their interview that we conducted. The fourth thing was about labeling and stigmatization in institutional encounter. Participants were concerned that this label kind of affect the level of non-compliance or being difficult, kind of affect the kind of services that they receive from this institution, which we can also see from the stories that participants have shared with us so far. So I'll turn it back to Tara. Thank you.
Thanks, Pat. So these next themes that I'm going to talk about are related specifically to the Indigenous relatives that we've spoken with. And the first one being anti-Indigenous racism is hidden in everyday services encounters. It's inherited colonial logic within professional education and training. And we see that from the first quote here that this community member told us that they experience racism everywhere. It just is where it is, and you'll experience it whether you like it or not. And that just really speaks to that anti-Indigenous racism being ingrained into all systems, so much so that it's difficult for folks to highlight because it's an everyday experience. Every encounter within systems and services is steeped within it. And that's through poor treatment and negative interactions with a variety of service providers within major institutions, not just healthcare, as Pat noted in her findings as well. But we've heard that that is the expectation. And service providers spoke in relation to this as well, one saying here that in the healthcare system particularly, and the service providers within those systems, that racism is very much coached into that system. And that was a common finding that was shared throughout a few different service providers in relation specifically to them referring to the point that Dr. Barry Lavalley has made before, specifically in the chapter in White Benevolence regarding Indigenous specific racism being coached into healthcare providers. And one of the ways that's done is the way Indigenous peoples are spoken about. And this service provider kind of highlighted that here when they said folks who primarily speak their own language can easily get incorrected or accused as being intoxicated. So this kind of discourse or thoughts around substance use, alcohol use came up a lot as well for folks from the community who expressed being labeled as drug seeking, accusations of diverting medications, and either blatantly being turned away and denied care, or just made to feel so awful that they left without being seen. And there was lots of other accusations, like I said, around drugs, alcohol, sexual partners that Indigenous people specifically experienced within the healthcare system, which are all those dangerous discourses and stereotypes that continue to follow Indigenous people, often specifically First Nations, that not only impede care, including access to HIV and STBBI testing and treatment, but ultimately lead to the death of Indigenous people within those systems. And that's all of which is kind of grounded in the second theme that we identified of being colonial control, colonial governance, and colonial surveillance. So this individual here talks about their experience with EIA or social assistance, whatever you might know it as. They talked about having had a really bad experience where they would ask for a little bit of emergency support and would get interrogated right down to feeling as though they were worthless. And that was multiple accounts of something similar to this from both community and service providers about EIA questioning, practices being almost like interrogative for people to prove their eligibility or disclose personal health information, including HIV status, to non-medical professionals in order to receive benefits that they were entitled to. There was also a lot of talk about surveillance surrounding people's bank statements, the requirements to report every dollar that someone receives, for fear, and then fear of being cut off if they weren't upfront with that. And this next quote spoke about CFS and talking about their health records being subpoenaed. And we already know that Indigenous peoples are avoiding healthcare systems because of how they're treated due to that anti-Indigenous racism. And then when they do seek care, they risk having their health information disclosed to a system trying to remove the children from their care, which is what this person was referring to. Other community members talked about having to jump through various hoops for CFS, attending mandated treatment and programming for addictions, where they, in those spaces, then felt pressured to self-disclose HIV status in order to remain in the facilities. Keeping in mind that obviously HIV is still highly stigmatized, and then that creates harm for folks as well. Many people also had experiences with social housing, the main one here obviously being Manitoba. And folks talked about how staff continuously bothered them, monitoring their coming and going, constantly checking in on them. Other people talked about being denied transfers. You have little choice really of what area that you live in, and are confined, especially as a single person, to the inner city. And that's speaking a lot to that governance of the control of movements for individuals within our systems. And these colonial systems create experiences of mistreatment and anti-Indigenous racism, having to behave a certain way, present for care at the right time, or to be sick enough not to believe, and creates conditional deservingness around these service encounters. So the first quote we see here is from a service provider who states that the expectation that patients be perfect when they go to receive healthcare, they can't be in a state of frustration. They're expected to communicate their needs in a perfect way at the perfect time. And if we think about this in the context of how Indigenous people are treated on a regular basis in everyday encounters with a variety of different service providers, as we just heard, to avoid care because of it, and then to present at a time of emergency, requesting support or requiring healthcare, to then be met again with that same discrimination or even turned away, as I just mentioned earlier. It's no wonder then that the common experience among community members was that it was becoming angry, and then feeling the need to express this. And the one individual here talks about lashing out at a bus driver because they were fed up of how they were being treated. And this was in the context of having no bus fare, being denied a ride to an important medical appointment. And this individual, faced repercussions of this as well as the other individual in the second quote here that talks about their experience with CFS. And these encounters are then used against Indigenous people. They're taken out of context of that colonial control, colonial governance, colonial surveillance, and then out of the context of the daily Indigenous racism that's experienced, to have the system then point back at a valid and normal response of anger and frustration, to then say that we as Indigenous people are the harmful ones, not the system itself. And I think for anyone that works in healthcare, myself included, I think that's really important if we think of those little purple flags that folks get on their chart to insinuate that someone's been aggressive or violent in the past, at least just one time. Those discourses, again, like we talked about earlier, come back around. They're there on someone's chart before someone's even had a direct interaction with someone, and those negative assumptions begin to form around them, creating this individualized problem versus a larger systemic one. But these collective experiences of harmful systems, including health, social assistance, housing, and CFS, are prevalent, but so is community interruption of Indigenous racism and resistance, which is the last theme we have here. So several community members talked about finding their own voice, being able to advocate for themselves and others. Community noted that the change in treatment that they experienced when they had a second person with them as a witness, demonstrating kind of that community care and the power of relationality, something that's kind of like intentionally left out of the system's design. Another community member shared kind of a bare minimum for service providers is to be, empathetic, not act like a robot. And this last quote came up in nearly every interview in some form. When asked how you know somewhere or someone is safe to access services, it was kind of collectively described as you just know. So this person says that people look at you, you know, they look at you funny or whatever, and you get that feeling in your head or your stomach, you know. And I did know right away what they were talking about, and I'm sure many of you know as well. And I think just as it can deter someone from accessing services there, it can also welcome someone, as many people noted as well. So although anti-Indigenous racism kind of is complex issue, individual persons within the system have the ability to address anti-Indigenous racism through our interactions, through our decision making, and how we greet someone when they walk through the door. We have that power to be able to lead with kindness each day. And of course, many community members we spoke to have found community outside of these systems, often through shared lived experience, connection to Indigenous service providers or programming where culture and ceremony was prioritized, which in turn then enabled folks to work on other aspects of their well-being, such as healthcare, stable housing, navigating CFS, and building relationships within the community. So what we're hearing is that there is an interlocking system of anti-Indigenous racism, and it's resultingly impacting HIV-STBBI's experiences. And it's doing so by attempting to individualize rising HIV-STBBI rates in the province through accusations of substance use and labeling Indigenous people as high-risk populations, when in the reality, it's not individual behavior shaping HIV or STBBI experiences, but a purposely designed system to exclude. And by the time an Indigenous person encounters healthcare providers, they've been bombarded with anti-Indigenous racism. And this isn't new information. Indigenous people have experienced this and shared this for a very long time. But these stories highlight specific key policies that contribute to things like EIA, housing, CFS, and health, and how changing or eliminating those could positively impact HIV-STBBI care in the province. And those positive experiences that people have had are rooted in relationship, demonstrating the need for a fundamental shift in colonial systems and services, and the implementation of Indigenous services and Indigenous-led systems and voices to make those shifts and uphold one another, which is already happening in some ways as we continue to be in community with one another, hearing stories of advocacy for one another, and Indigenous-led services that exist that folks are seeking. But we do need more of those. And Pat will talk a little bit about her perspective from the ACB community, but just hearing Pat and you know, these themes as well. There's obviously lots of differences, but I think lots of commonalities as well. What stands out for me is both Indigenous and ACB communities are over-surveilled through CFS or EIA, as well as simultaneously underserved through health and housing. So I think we're all looking forward to diving into that more and hearing more from community. So I'll hand it over to Pat.
Thank you.
Are you there?
I've mentioned they have some commonalities, but there are also some specific issues that impact the Black population specifically. One of it is the anti-Black racism, which contributes to stigma surrounding HIV, and which kind of prevents ACB community members from accessing prevention services, assessing treatment or interaction with these services, right? So without this access, it means we continue to see the rise in terms of the gap in inequalities among this population. Another one is immigration status, right? Which specifically affect how people, Black population specifically, access services, right? For people with temporary status or people who don't even have status within Canada, it means their access to these services would be far worse than other people. So we see this barrier that ACB committee members face in assessing this service. So think about the fact that in terms of assessing healthcare, you have to give an address. You have to have a health card. And for somebody that don't have a status, it means this would not be available to them. And also, there is also the narrative about Black population as the vectors of HIV. So this kind of impacts how our community interact with system, especially when we talk about healthcare system and how we interact, going for testing, going for treatment, because the narrative is there, and also kind of impacts how service provider interact with ACB population. So these are some of the ways in which it has showed differently for ACB community members. So there's fear of deportation, there's already the stigma, that is ongoing discussion within the communities and all that. So this kind of impact HIV within our community. So those are the additions I'm going to put. Thank you.
Thank you both, Pat and Tara. Next steps for our project is that we're going to be gathering to honor stories, the stories that you heard today, the stories that have been shared with us, and you know, ongoing stories through ceremony. We're going to continue meeting with our community guiding circle, making sure we're on the right track with these preliminary findings, and continue engaging with them in our research. We're also going to do some member checking. So we're going to check in with people that have shared their stories and make sure that we're capturing, that we've captured their stories properly, that they're validating our what we've captured. And we're still conducting interviews. We're particularly interested in interviewing some more people from the ACB community, but we're still also interviewing people from the Indigenous community.
So thanks everybody for your time, and hopefully an opportunity to share these stories with you. I think we're ready for questions.
Thank you all so much. There is one question in the Q&A feature, and for other folks on the call, please feel free to add your questions. So this person says, at Tina's Safe Haven, we occasionally have a post-exposure incident where the person refuses ER or urgent care visit as it feels unsafe. Where could we access PEP after doing a point of care HIV test kit on site?
Yeah, so I would recommend.
I was just going to ask Ella if I could stop sharing this. Go ahead.
Do you want me to answer that question, or do you want to talk, Tara?
No, you go ahead.
Yeah, so I think if they're not wanting to access ER or any clinical spaces, there's always the Manitoba Sexual Wellness Lodge that has nurses there Tuesdays and Thursdays from 11 a.m. to 3 p.m. And they would probably be the best people to discuss this with. It's also good to remember that point of care tests that somebody may not react to antibodies for a number of times. So ongoing testing would be recommended as well.
Thanks, Melissa. Any other questions from the audience?
Just want to add to that question, or comment to that question, like things like PrEP should be available everywhere, right? And everybody should know how to or where to access it. So that is one of the issues that we are seeing, and we're finding the fact that people don't even know, and also the fact that even when it is there are barriers that prevent people, like especially when I think about people from my community, people without status, people with temporary status, then access is really far for them. So I think this is part of what we are doing, that we really need to look at that, because that is the only way we can bring the numbers down for Manitoba.
Can people?
Yeah, and I think the other piece too is, for the Indigenous population, I'm aware that Manitoba Health or Manitoba government has had an Indigenous HIV strategy since 2004. It was never implemented, and this is where we are today. We have the highest rate of HIV transmission in Canada, and a large proportion are Indigenous people. So definitely in the public health domain, it was something preventable, but now we're experiencing that. And the World Health estimates for care costs per person with HIV is about $1.4 million, right? And for Manitoba, since 2021, there's been 1,050 new cases of HIV. That's $1.4 billion in healthcare. And the taxpayer is going to pay for that because public health has not reacted to the reality of transmission in this province by having dedicated funding for strategies, for interventions, for HIV prevention campaign that includes information about PEP, where you get it, who's mandated to give it out. Is it a pharmacy, right? Low barrier access. We don't have any of that in Manitoba. And I'm not just talking about Winnipeg, I'm talking about rural communities, on-reserve communities. We have 63 First Nations in Manitoba, northern and remote communities. We don't have any guiding principles. We don't have any guiding policy about this. And again, and that's why we have the highest rate of transmission in HIV in Canada, is because of the stigma around HIV. You saw during the COVID-19 pandemic how quickly systems responded across the board and how much billions of dollars were dedicated to preventing this pandemic. HIV, it's a slow process. We'll wait and see. And then the numbers just keep increasing. The estimate for 2008 is 1,008 new cases of HIV for Manitoba at the rate we're going at. And, when outbreaks happen, they're fueled by the behavior, and those behaviors don't stop because we fund a policy or we fund a strategy. They keep going forward, and we will see an increase of HIV in Manitoba for probably the next 6 or 7 years. And it's because there were no interventions. And we've had a generalized approach to HIV in Canada and in Manitoba because of that stigma around sexuality, drug use. We're very conservative in our approach to sex or drug use in this province, in the country, and it shows. It shows. We have no campaigns, no bus stop campaigns about HIV prevention, or even the PrEP, the pre-exposure prophylaxis. Nothing. You can fly to Thompson and you look in the airport. There's no posters there about HIV. Thompson, anywhere. And people are constantly flying back and forth from Nunavut, northern Manitoba to Winnipeg and back again. And there's just no information. Sure.
This maybe transitions well into the next question that we have in the Q&A, which is if you'd like to speak more to recommendations, actions, or strategies to address racism in healthcare.
Well, for myself, I like the ACT UP philosophy that began in the AIDS movement years ago when, there was lack of treatment, lack of access to the antiretroviral drugs, and it was community advocacy, community activism, kind of like I Don't Know More that happened in Canada around Indigenous rights and MMIWG. And I think that's required because systems are sort of, they don't hear, they don't see, and they don't think, and they need to be woken up. That this is a public health emergency for Canada, for Manitoba, and those who have access to legislation and policy need to act now. And so, our voice needs to be out there. We used to have the AIDS Walk every World AIDS Day. We don't do that anymore, so we're not visible in the public. we've really, just become silent in this whole process. So I think a lot more activism out there to call people out, and the life expectancy for Indigenous people right now in Canada is 15 years less than the general population. With HIV, it's going to be even less than that, like half the expected lifetime of Canadians if you're diagnosed with HIV in this country. And that, we're a first world country, but we're enabling this to happen. And it doesn't need to happen. That's the point. We have the drugs, we have, the level of care, but it just keeps continuing. So, and that's my job, right? Is really to review the legislation, to review policies, and call people out if they're not following them.
Thanks, Albert. Anyone else on the team want to respond to this question? Just any recommendations, actions, or strategies to address racism in healthcare?
Yeah, I think one key strategy. Oh, go ahead, Richie. Go first.
Yeah, I just wanted to add, I would say take the cultural sensitivity training more seriously, because from my interview with participants, it's just there. The onboarding process is just there, like something you need to do, but it's never taken so seriously. So people come in. So I think they lack this sensitivity or cultural awareness. So we really need to see how to make this institution really take them seriously. And with time, we'll know. And also community members talk about representation, right, in these institutions. That would also help address these issues. Thank you. Yes, Ross.
Yeah, I think my answer also kind of follows what you're saying. Obviously, cultural sensitivity and cultural competence is very important, but also we might want to think about key strategies is how to move beyond individual cultural competence or in trainings and focus more on things like institutional accountability, right? So many findings in this project really relate back to the system. So what is institutional accountability for anti-Indigenous racism in healthcare? What's institutional accountability for anti-Black racism in healthcare? I think that means possibly examining how policies, how practices for those institutions are taking place. It could be something like conducting, equity audits. It could be something like monitoring disparities in access to prevention, to treatment outcomes. It might be about creating mechanisms for communities to hold institutions accountable. So I think we kind of need to think about this more systemically for about systems change.
In addition, I would think I'll add more. I'll still call it representation in terms of policy development, because what we find is that most of these policies have been developed and brought in. So because there's no much representation, that's where you find a situation where the policy is not reflective of what is really out there or what people need. So we need to, yes, hold institutions accountable for that and call for more representation. Thank you.
And I think too, just to add to that piece, like community has said, one of our questions is, how would you like to be involved to see some of these changes happen? And everybody just kind of laughs and said they could just ask us, because the systems and places that nobody's asking community to join the table. And I think if our systems and policies are making up recommendations and actions for, and you're looking around the table and there's no representation, like Pat was saying, it doesn't make sense. It's not going to work. So I think pushing for that. And then obviously at the micro level, community is, shared with us exactly like leading with kindness. I think Dr. Lavalley talks about that too on an individualized basis. So those are like actionable things for us as practitioners to do immediately. And then of course, like Albert says, holding as service providers each other accountable too when we witness that, not just letting it happen, I think is an important part. Sorry, Albert.
Yeah, I think the other thing is, if I can remember my point, oh, it's gone now. Yeah, I've watched and public health does collect ethnic identifiers for HIV because, they want to get people antiretrovirals, etc. to care, because it's treatment as prevention methodology is if you bring the viral load down, you reduce transmission and increase CD4 levels, increase quality of life. And so I've seen that, in Manitoba, we do use ethnic identifiers since, I'm trying to remember what year that was. It began 85. So we do know which communities are affected, by HIV transmission, including Indigenous. And so I've watched those Indigenous epi reports move from about 20 years ago, 20% per year. It's now around 80%. So to me, where was public health in monitoring the epi data and preventing the increase when it was at 40%, when it was at 60%? And that's what I mean. That high level of inclusion of Indigenous people in this epi data is normalized in public health. So there's no intervention, right? Like you would act to decrease it, not just monitor the rising rate of HIV among Indigenous people and African, Caribbean, Black people. You would put interventions in place. Otherwise, why collect epi data if you're not going to use it, right? So that's an issue right there. Is how is that epi data being used? Because they are every year they collect ethnic identifiers and they know where the concentrations of HIV are in this province. Yet we do not see those, outreach designed to these populations. And so, interestingly, First Nations Health and Social Secretariat of Manitoba just passed a resolution last month, that the First Nations of Manitoba would develop an HIV strategy. Finally, right? And that really follows the Public Health Agency of Canada Action Plan, the renewed one, is that, and the first one is to engage Indigenous leadership in the response. And this is a representation of that when it is the First Nations leading that development of that strategy.
Thanks, everyone. A couple more questions here. One is asking about if the study looked at stigmatization of 2S LGBTQA+, and specifically the person is asking about stigmatization like within cultural and racialized communities. I wonder if you'd like to speak to that.
Sure. Our study, we did not specifically recruit participants based on 2S LGBTQ identity, but everybody was welcome to be part of the study. So we cannot really draw conclusions about layered stigma related to sexual orientation or gender identity. That would not be appropriate. In terms of the layered, but participants did talk about the layered stigmatization, especially with regards to other social locations, like homelessness and substance use and living with HIV and being racialized Black or Indigenous person. So that's really where it came up. But the focus of the interviews was primarily on experiences of structural anti-Indigenous and anti-Black racism and differential treatment within those systems.
Thanks, Rusty. The last comment we have here, and folks on the call, we still do have a few minutes if anyone else would like to add a question into the Q&A feature. We have a comment about RC Poly is hosting a sexual health assessment and testing clinic for all staff and students, including testing and education in collaboration with Norwest Co-op Community Health. So a community event-based testing event, it sounds like, which is fantastic. And the person asks, what else could we do? So I guess maybe more broadly, this question could be about how groups that aren't necessarily healthcare providers can be more engaged with their community and event-based testing and those kinds of things. So if you have any comments on that, that would be great.
Yeah, I mean, many things one could consider in addition, like, educational workshops, workshops on stigma reductions. One might consider providing free prevention resources like condoms, dental dams, information on PrEP, PEP. Might be also valuable sometimes to partner with community organizations that provide culturally safe services, Indigenous-led organizations. So that could be also an avenue to explore.
I notice at a lot of our Indigenous conferences in this city, there are no booths talking about sexual health, HIV, or STBBIs, which is denialism, right? And that's a critical resource, especially at health conferences that are Indigenous or women's conferences. There's nothing there, right? And that's the stigma, right? Not just about HIV, but talking about sexual health generally. There's a female condom available now, a new one in Canada. Well, we never see it. We never see it at conferences, at events. People don't know it exists. And just information, PrEP is covered by the non-insured health benefits for First Nations. There is no charge. And people don't even know it's available. And they can contract HIV. But if they had it in their blood, 99%, there wouldn't be any transmission. There wouldn't be an infection. We're just not having the information rolled out in the community because of the fear of talking about HIV and STIs or sexuality in general. We have to get beyond that if we're going to prevent transmission or properly care for people who are living with HIV in this province.
Thanks, Albert. Right, this person is just commenting that they're hearing part of what they can do is more awareness and destigmatization on campus, which I think is exactly what we're hearing from our presenters. Those are all the questions that we have at this point. We do have a few more minutes. Oh, here we go. Another question. Based off of your work, what have you found around how people would like to receive information on prevention, treatment, and education? Where and how do people want to receive testing/care?
I think it's a combination. We have the self-test kit for HIV available in North America for people who are not ready to go to a health center and get a test, whether it's the rapid test or the blood draw test. They can order this online. It's self-care. It's a self-test, and that's so there's that option. And then you can reach out to organizations like Nine Circles Community Health Centers, the Sexual Wellness Lodge, who are doing a lot of this work in the community. And, we do have sexual health events throughout the year. And then World AIDS Day is on December 1st, where you can do a lot of activities, even fundraising for yourself or for, anybody who might be diagnosed with HIV. And so there's a lot of creative ways that that conversation can be had. And just reaching out. There's the Manitoba HIV program at Nine Circles Community Health Center. So there's a lot of, and I'm trying to think, the Collective Impact Network has a lot of the organizations listed on our website. So if you want to check there, and I think with the Village Lab on their website, they identify a lot of components of a response there as well. So I would check both of those out.
Thanks, folks. And we will send out the links for those websites as well when we send out the recording of this webinar. And we'll make sure that it's also in the YouTube description.
I just wanted to add to that as well, in terms of from this research project of the individuals that we've specifically spoken with, I think lots of folks do identify those community-based resources, places that they can build relationship, be in relationship with people. That's kind of been the across the board where people feel most comfortable. But I think the most common thing that folks tell us is that they want to have a say in that, to be asked, to feel that they have autonomy of where they get that. So I think for each of us, like asking people and having those conversations with people is important as well.
Just want to add that holding institutions accountable would serve the purpose more, because if we keep coming to it from the individual level, for example, if going to access this program or these services, the person is not met with the kind of services they receive, the response they receive, then they will stay back. So I think we need to start addressing it at those institutional level. That will make more people more willing to appreciate. I know there are community service there. I know there's testing. I know, but people are not going, which is one of the reasons why they are not going, is they don't feel those services or those programs meet their needs, or it's not culturally sensitive, or the way they are being treated at these different institutions. So I think we also need to look at it from that aspect. Thank you.
Thanks, everyone. And I see Albert has read the next question here, which is just about what's the role that social media can play in this, or do you think that social media can help?
Yeah, I said, you could follow Nine Circles Community Health Center on Facebook. And, some of these resources like Communities Information Treatment Exchange are online on Instagram, and sort of the common platforms you will find HIV information and resources.
On the Village Lab website, we have an infographic library that offers lots of information about different information related to sexual health.
We also write a letter to our Minister of Health asking where our HIV action plan is for Manitoba.
Awesome. Lots of great information and follow-ups for folks. Yeah, we're at almost 3 o'clock here, so I just want to thank all of you for your time in presenting and for your great work in this area, and to everyone on the call for your time and listening and your fantastic questions. Again, we will be uploading this onto our YouTube page and sending out an email to everyone on the call today with that resource, as well as the contact information for the Village Lab and the Collective Impact Network. So thank you all again, and I hope everyone enjoys the rest of their day.